Good evening, everybody. I am Rehab Magdi, lecturer of neurology, Cairo University Epilepsy Unit. Thank you for giving me such opportunity to introduce this webinar. Welcome to all attendees. Welcome to all our expert guests and our honorable speaker, Dr. Riham Shamloul. I would like to introduce Professor Riham Shamloul, Professor of Neurology, Cairo University, Administrator of Cairo University Epilepsy Unit, to share her experience and knowledge about when to start and when to stop anti-seizure medications. Professor Dr. Riham, could you start, please? No, the voice we can't hear, please.
Assalamu alaikum. Greetings to all our audience and to our moderator, Dr. Rehab Magdi, who is a dear colleague at Cairo University. I'd like to take this opportunity to thank the organizers and the members of the East Mediterranean region for giving me this opportunity to present a topic on when to start and stop anti-seizure medication. So let's begin. The question is when to start anti-seizure medication. So can the answer be as simple as, well, when you diagnose a seizure, you start anti-seizure medication? Well, unfortunately not. This is because epilepsy is not a simple disease. Well, there are certain issues that should be considered before initiation the anti-seizure medication. And those include, you have to first decide, is it an epileptic seizure or not? Is it seizure provoked? Is it liable for recurrence? And can the patient accept the diagnosis and accept treating by anti-seizure medication? Well, let's start with the first issue. Is it an epileptic seizure? So what's the diagnosis of epileptic seizures? Well, let's go back to 1993, where the Commission on Epidemiology in the International League has proposed a definition which stated that epileptic seizures are clinical manifestations that are presumed to be a result from an abnormal and excessive discharge of a set of neurons. Well, this definition stood still till 2005, where very minor changes occurred, and it stated that an epileptic seizure is a transient occurrence of signs and symptoms due to excessive and synchronous neuronal activity. So if it is an epileptic seizure, so are there others non-epileptic seizure? Well, yes, and they are termed epilepsy mimics. Well, these are conditions that result in neurological transient disorders, but are not due to abnormal and synchronous activity of the brain neurons. They include, but are not limited to, syncope, sleep disorders, movement disorders, migraine, and dissociative seizures. The physician should be aware of these mimics in order to not misdiagnose them with an epileptic seizure. So, are they common to be presented with epilepsy mimics? Well, let me here refer to a study that was published in 2020, where the authors tried to detect the incidence of first epileptic seizure versus seizure mimic and other epilepsies. And they reported, but by the end, the incidence of a seizure mimic almost equals that of all seizures. Thus, if you are a physician, you are liable to be presented with an epileptic seizure equally as you can be presented with a non-epileptic seizure. So the first part in our steps towards the approach to start anti-seizure medication is to confirm the diagnosis that the seizure you are presented with is an epileptic seizure. So the second issue, is this seizure provoked? Well, by definition, provoked seizures are those that occur in temporal relation with an acute insult to the brain, whether a systemic metabolic toxic or an acute CNS insult. Well, epilepsy is not defined when the brain responds to an acute insult. No, epilepsy is defined by a disorder that is characterized by an enduring predisposition to generate epileptic seizures. So a normal brain that responds to an acute insult is not considered epileptic. An epileptic seizure should be unprovoked. And this is the second step that we should target during our approach to start the seizure medication. After confirming that it is an epileptic seizure, we should further confirm that it is unprovoked. So let's go to our third issue. Is the seizure liable to recur? Well, the good news is 10% of the people may experience one seizure per their life, but only 1 to 2% continue to be diagnosed as active epilepsy. And the risk to develop a second seizure after the first does not exceed 50%, while that of the second seizure rises up to 70%. So the guidelines of 1993 has proposed that an operative definition for epilepsy, stating that an epilepsy is a condition that characterized by the recurrence of 2 or more epileptic seizures unprovoked. Well, although this definition has protected many people from being misdiagnosed by epilepsy, however, the diagnosis in certain patients has been much delayed and their management also. So as the knowledge of epilepsy became clearer by the years and more epidemiological studies were published, now it is known that epilepsy could recur after a second seizure with a range of 27 to 71%, meaning that certain people have a very low risk for epilepsy recurrence, while others have a high risk for epilepsy recurrence. And when a seizure recurs, well, it has its consequences. And let us here mention that most important consequences of seizure are related injuries in addition to psychosocial consequences. So let me here also refer to a paper that was published in 2019, which detected the risk factors in epileptic patients and stated that around 25% may be exposed to water immersion, followed by head injury, burns, dental injury, seizure while diving, and fracture. All these are very harmful consequences for the patient, in addition to the psychosocial negative impact of recurrence of seizure. So, in recognition of all these negative impact on the patient, another definition was proposed in 2014, and this definition stated that epilepsy is a disease of the brain defined by at least 2 unprovoked seizures with 24 hours apart, or 1 unprovoked seizure, but there is a similar tendency to recur that exceeds 60%, or the diagnosis of an epilepsy syndrome. Well, this definition really helped in early diagnosis and management of epilepsy patients. However, it poses 2 ambiguities. First, what are the factors that may increase the risk of recurrence to more than 60%? The second is when you diagnose an epilepsy syndrome, you need good knowledge of the clinical picture, and you may rely on investigation like EEG and MRI that might not be readily available or optimally done. So in order to bypass this limitation, physicians should be aware of the factors that increase the risk of recurrence more than 60%. Well, these factors were collectively reported in a review article published in Seizure in 2017, and they included extremes of age, patient with epilepsy onset less than 2 years and above 50 years have a high risk of recurrence. A female gender showed in some studies was reported to have a higher risk of recurrence than a male. Positive family history in a first-degree relative. Focal epilepsies when they present as a type of seizure. The presence of multi-seizure types, if the first seizure was nocturnal, if the etiology was remote symptomatic cause, the presence of neurological abnormal examination, the presence of epileptic activity in the EEG, and positive neuroimaging showing a structural lesion in the brain. All these factors may increase a recurrent risk of the patient, and the physician should be aware of. However, the physician carries no burden to specify the recurrent risk in every individual. But again, the physician should go thoroughly through the history to elaborate 2 important points. First, Was this seizure really the first seizure? And can I diagnose an epilepsy syndrome? Why should I insist or try to detect if it was the first seizure? Well, because many seizures pass unrecognized, like absence, myoclonus. These semiologies may be not detected as an epileptic phenomenon. Many seizures are unwitnessed, like those that occur during sleep, and many seizures are unremembered or even denied by the family. The second step that we should also detect is that the seizure should have passed at least 24 hours between the first seizure and the second one, because multiple seizures within the same day are all considered as one event. Let's move now to diagnosis of an epilepsy syndrome. Well, we were privileged in 2022 by the publication of 4 positional papers that comprehensively addressed the syndromes, their clinical picture, their EEG, their MRI, and their possible related investigations. I really advise everyone to study these papers comprehensively. And once we just mention epilepsy syndrome, I guess genetic workup pops up in our mind. Where can genetic testing help us in detecting recurrent risk? Well, up till now, genetic testing has helped in identifying certain epilepsy syndromes and their specific management. They shed light upon some prognostic information. However, the knowledge of the science of genetics is still not properly addressed by many clinicians. And thus, we still have a recommendation from International League of 2015 that said that genetic testing should not be undertaken in a primary or secondary level. But as we can follow now, that with further publishing of genetic study, we know we are very close to detecting a genetic test that will help us in detection of the recurrent risk in epileptic patients. So, what about the steps now? First, we said that we should confirm the epileptic seizure as being epileptic. Second, we should make sure that the seizure is not provoked. Third, that we have to assess and estimate the factors that are related to the recurrence risk and that they possibly may exceed 60%. Now, can we start the seizure medication for the patient? Well, no, the patient has to say yes. And I don't mean, of course, that we are proposing, but the patient has to accept the diagnosis of epilepsy and the starting of anti-seizure medication. So, well, why would the patient deny or refuse the diagnosis of epilepsy? We all know that epilepsy has stigma. Seizures may not occur, and I can't tell you which patient will the seizure recur or not. Anti-seizure medication, yes, do not cure epilepsy, and the side effect of anti-seizure medication may occur, and being adherent to a certain drug for a long time is very difficult. All these issues should be addressed with the patient before starting the anti-seizure medication. If we say that the stigma of epilepsy is bad, well, the consequences of seizures are also bad, because as we said, it may relate to injury, psychosocial impact, and thus it is not accepted to take the risk of further seizure if you have high risk. Also, seizures may recur in a wide variety of certain people, may ranging from 21 to 45, but in some it's reported to 70% risk of recurrence. Anti-seizure medication, yes, do not cure epilepsy. However, it is well known that they decrease a short-term risk of developing additional seizures. So that anti-seizure medication will decrease the risk by 35% of developing of seizures in 2 years. However, it may not affect it at the long term. Side effects occur in a small number of percent of patients, ranging from 7 to 31, and they're easily controlled, and they can be prevented if we go slowly and starting by low doses. Compliance is difficult, but abrupt withdrawal can have bad consequences as provoking seizures. We also have to take the personal factors into account: the occupation, the patient, residency, personal and psychological and psychosocial state. So, if you back to when to start anti-seizure medication, is it the right question? I think if we can modify it by stating that when to start the right treatment on the right time for the right patient, is this the appropriate one? Now, once you confirm an epileptic seizure, confirm it is provoked, confirm that you have a seizure recurrence risk more than 60%, and the patient has accepted to start anti-seizure medication, now the ball is in your hand. You have to choose a well-tolerated drug that is appropriate for the seizure and start it in its adequate dose. I hope the dilemma of starting anti-seizure medication at this stage is more or less clarified, and a feeling of confidence in your approach is starting to develop. However, unfortunately, this feeling may not last long when you are faced with the most expected question from the patient when he says to you, "Well, doctor, till when should I continue my anti-seizure medication?" And here we enter another dilemma. So really, when can we stop the anti-seizure medication? Is it as simple as when the seizure stop the anti-seizure medication? Well, of course not, because epilepsy is not simple. There are also certain issues to consider before withdrawing the anti-seizure medication. And this include, why will the anti-seizure medication be stopped? When shall withdrawal begin? Who is the candidate for withdrawal? And how will the anti-seizure medication be tackled? Let's address the first issue. Why should an seizure medication be stopped? Well, if the patient became seizure-free for a considerable period of time, you should start a anti-seizure withdrawal. Secondly, if he is a child that is suffering from one of the self-limited epilepsy and he has outgrown his seizure, we should start anti-seizure medication withdrawal. So let's give a hint on self-limited focal epilepsies. There are certain type of epilepsy syndrome that has identifiable criteria. They all start at the childhood period. They have good prognosis. They remit by puberty, and they have a characteristic semiology and the EEG picture, and the brain imaging in all is normal. So passing to the third or less common scenarios for stopping or withdrawal anti-seizure medication, well, if the dose is ineffective at maximally tolerated dose, you should withdraw it. If a dose-related side effect or idiosyncratic reaction occurred, or if the patient is approaching conception. The third issue is, when shall withdrawal begin? Well, here the physician should also thoroughly revise the history from the patient to verify the date of the last seizure. And here we say any type of seizure, whether it's an aura or abortive or nocturnal seizure. As we said before, some seizures are not considered as epileptic phenomena by the patient. So we have to verify thoroughly what the date of the last seizure at any type of seizure. Well, a considerable period of seizure freedom should have elapsed. It is estimated about to be 2 years. However, this period may be shorter in certain conditions and prolonged in others. It may be shorter in children with self-limited syndromes where seizures have been controlled for an adequate period of time, or prolonged in certain patients with high risk of recurrence. And this will lead us to the second question. Who is candidate for withdrawal? Who has a high or low risk factor for seizure recurrence? Well, the high seizure recurrence is associated with also extremes of age, history of febrile seizures, the presence of a developmental delay or neurological deficit, multiple seizure types, and especially tonic-clonic seizures, certain epilepsy syndromes like the one presented in the right-sided table, Ohtahara syndrome, Knox-Gastaut, juvenile myoclonic epilepsy, reading epilepsy, and if the etiology of the seizures is remote symptomatic, the longer epilepsy duration before remission, if there is high frequency of seizures before the patient enters in remission, if the patient or the seizures were controlled on polytherapy, presence of abnormalities in the EEG, and the presence of abnormal neuroimaging, and finally, the early recurrence after a previous attempt to withdraw. All these factors are considered as high-risk factors that should be addressed before you start withdrawing your medication. But are these the only factor? Well, as we stated before, personal factor has great impact. The patient has to say yes, meaning if the patient's lifestyle will be severely impacted by a second seizure or a seizure after withdrawal, he can continue on one tolerated drug rather than experience the risk of a second seizure. So the patient has to accept the withdrawing his medication before we attempt the withdrawal process. So what is the withdrawal process and how should we stop the anti-seizure medication, or there are tapering regimens that we should follow? Well, in general speaking, we have to very slowly taper benzodiazepines and barbiturates, and the tapering should extend to weeks or even months according to the dosage. If hypersensitivity or life-threatening idiosyncratic reaction occur, this is the contrary, this is the other extreme. You have to immediately stop the offending drug and substitute it by a rapidly acting anti-seizure medication. You can start by tapering 10 to 25 of the total dose every 2 to 4 weeks, meaning you can taper within 3 to 4 weeks and at most for 9 months. No definite data are available to detect the best regimen of tapering, but we can highlight certain issues, like that phenytoin and valproate can be tapered over a few days to zero. Carbamazepine, lamotrigine, and vigabatrin can be tapered more slowly over 2 to 3 weeks. In case of polytherapy, changes of the dose of anti-seizure medication should be taken once at a time, done sequentially, and a period of 1 month may elapse between one drug and the other. The patient should be followed within the first 2 years, as these are the period with high seizure recurrence following withdrawal. If recurrence occur, reintroduce the doses that you started your withdrawal from. You don't have to increase the doses with reinitiation of the anti-seizure medication. The process of withdrawing the anti-seizure medication should be adequately planned, and time is a great factor in this plan, because there are risks of delayed withdrawal of anti-seizure medication. It is not right to keep the patient on anti-seizure medication where there is no verification for this, as this may lead to false impression of the patient of being unhealthy, and this has a very negative psychosocial impact. Long-term side effects of anti-seizure medication, like cognitive impairment, behavior affection, teratogenicity, you are subjecting the patient of a lot of anti-seizure medication side effects that he is not in no need for them. And we have to take into consideration also the financial burden of the anti-seizure medication. But what if we withdraw early than we should? Well, the risk of early withdrawal include also the first false impression of being cured, and when a seizure occurs, the patient will have significant psychosocial impact. We should note that less than 20% of the seizure, when they recur after withdrawal, may be uncontrolled, in addition to increased risk of SODIP after recurrence of seizure. So kindly avoid this inappropriate withdrawal of anti-seizure medication, and you have to choose the right time for when to start the withdrawal process. So our path to withdrawal anti-seizure medication should be start by, you have to ensure complete seizure freedom, and as we stated, all types of seizure. You have to ensure that there is an adequate period of seizure freedom has elapsed, that the patient now has a low risk of seizure recurrence, and you have to choose the appropriate plan to taper the anti-seizure medication by type and number. Counseling of the patient before withdrawal of anti-seizure medication is of utmost important. You have to put the details of the plan with the seizure and the caregiver. You have to tell the patient that even if he has being seizure-free for a long time and the epilepsy is resolved, he still has a higher risk than the general population to develop epileptic seizure, so he's not completely cured. No current method to identify who will enter complete remission after the process of withdrawal, so we have to take the risk. The risk is at highest in the first 6 months, so you have to take care during this period. A follow-up period of 2 years should be done because 35% might experience a recurrence of seizure in this period. Anti-seizure medication withdrawal is not an independent risk factor for seizure recurrence. If seizure recurred, it would have recurred even if we did not start the process of withdrawal. During withdrawal, you have to avoid all risky situations as driving, bathing alone, and so on. All these factors should be well elaborated to the patient, but not withholding him from the process of withdrawal, because we must confirm that 65% of the patient that will withdraw the anti-seizure medication will remain seizure-free and epilepsy will be resolved. So please, dear audience, kindly keep in your mind, epilepsy results from different brain diseases, and patients with epilepsy require different approach. Each patient is an individual that you should target and tailor the withdrawal process or the initiation of the drug according to his characteristics. Dedicated clinical diagnosis and investigation help in the management decision. Thus, when you ask for an investigation or you order MRI or EEG, please make sure that they are done well according to the standardized protocols in order to help you in your diagnosis and estimation of the seizure recurrence risk. A second seizure is not always harmless, and the anti-seizure medication surely have side effects. Epilepsy by all has stigma and drug adherence is difficult, but also we can lose our patient if we do not start or stop the anti-seizure medication in the right time. Finally, initiating and withdrawing anti-seizure medication is a scientific art, which requires knowledge, skill, and compassion with the patient. And finally, keep in mind, epilepsy is not a simple disease. Treating an epilepsy patient is a long journey, full of decisions that should be taken by both you and the patient, and hopefully these decisions are always right. Thank you for being with me all this throughout the presentation, and I thank all our organizing committee and our moderator. Thank you.
Thank you, Professor Riham Shamroon, for this valuable lecture. Really, it is very interesting. Now, we are waiting for any questions from the audience. Please, anyone has a question, you can write it in a chat. If anyone has a question, you can write it in a chat. Okay, we can wait for 5 minutes. Okay, now we have some questions. Someone asks if a patient with West syndrome, seizure-free, with vigabatrin for 6 months, can we start withdrawal?
Yes, thank you, Dr. Rehab, and thank you for all the audience. You have to refer here to the risk of recurrence. Is West associated with any brain abnormality? 6 months, I think, is very early to think for seizure, anti-seizure medication withdrawal. But you have to define if any other disorders are present. Is there any brain abnormality? Do you have any family history? Does the patient have any neurological deficit? You have to collectively detect any other risk factor for this patient to develop further seizure, but being one of the seizure syndromes with mostly cognitive impairment present, I think it is too early for you to withdraw anti-seizure medication at this period of only 6 months interval.
Okay, thank you, Professor Ilham Shamroon. Another question. Someone asks about, can I withdraw anti-seizure medication in hemiplegic CP? And he was free for more than 2 years.
Yes, okay. Meaning a hemiplegic that he has a brain lesion that he's one of his there is a hemispheric insult in a brain, all the trauma or infection or hemorrhage. Well, this will make him at a higher risk for developing a recurrent seizure. Again, you have cognitive impairment, you have neurological deficit, and you have a structural injury in the brain. All of this will increase the risk of recurrence for this patient. So 2 years, as again, is not enough for you to start withdrawal. I would recommend you to prolong the duration before you start the process of withdrawing the anti-seizure medication.
Okay. Another question. What about EEG abnormalities in trying to withdraw?
Yes, sure. Many studies have published the risk of presence of abnormal EEGs as a factor to take a decision whether to withdraw or not to withdraw the anti-seizure medication. The presence of abnormal EEG may increase the risk of recurrence. However, it is not by its own if you have all the other factors are low risk factors. So you have to know you should not delay based on your EEG, only the EEG. If the patient has complete seizure freedom, he has no other risk factors, and he only has abnormal EEG, then this is not a single factor to delay your withdrawal. No, you can start withdrawing, but you have to follow the patient more frequently.
Thank you. We have a question. How do you stop medication post-surgical, especially temporal lobe epilepsy?
It depends on the outcome of after surgery. Many people after surgery, you continue on the regimen they started before surgery, but you have to follow the patient to detect if seizure will recur post-surgical or not. So according to the outcome, the Engel +1, +2, what is the outcome following the surgery, and then you start withdrawing gradually. You have to keep the patient at least 6 months before withdrawing on his previous anti-seizure medication, detect the outcome, detect the risk of the patient, and then you decide to withdraw your anti-seizure medication.
Okay. Another question. If an old patient has been on phenobarbital for years and still not free of seizures, is it safe to withdraw phenobarbital while introducing lamotrigine or or levetiracetam?
Well, if you follow rational polytherapy, if you are trying to add on in an uncontrolled patient, well, you start by adding on the drug you expect to control the seizure, and once it controls, then you gradually withdraw the drug you find not controlling the patient. So I would go that you please add on first, then once the patient seizures become controlled, start gradual withdrawal of this drug that didn't have good outcome by the patient.
Thank you. Now, when can we consider a patient seizure-free?
Well, this is a tough question because each patient, as we said before, has his individual characteristics. It depends this patient, what type of epilepsy is he suffering from? Is he a child? Is he an adult? Is he an elderly? All the risk factors should be probably weighed, and then you detect if the patient is seizure free or not, because he will not be seizure by definition. He must be, number one, he must be not drug resistant. He must be, say, at least 1 year or 3 times the interval before starting the anti-seizure medication. Then you assess the risk of recurrence. Then you detect how many or how much time should elapse before you consider him as seizure free. So it will depend on many factors before you can say that the patient now is seizure free.
Yes. Okay. What is meant by unprovoked seizure? Somebody else?
Yes. Unprovoked seizure are seizures that occur without an acute insult to the brain. Previously, they defined it previously. They are the remote symptomatic, mean that either the brain had been injured in about several times before developing of epilepsy, like a previous stroke, a previous infection, a previous trauma, and then the seizures began in a not in temporal relation with the acute insult. They also said that unprovoked seizure is genetic epilepsies, idiopathic seizures, cryptogenic seizures. All of these terminologies was defined by unprovoked seizure. It's easier to define the provoked seizure because they are more easier to diagnose. Any insult to the acute insult to the brain is a provoked seizure. Any insult to the CNS, like infection, trauma, and the seizure occurred in close proximity, this is provoked. Any electrolyte metabolic disorder that known to provoke seizures are provoking seizures. Other than that, they are unprovoked.
Thank you. Someone asks if the patient is on polytherapy of anti-seizure medication. He asks about the sequence of tapering anti-seizure medications. Which we decide to taper first?
Okay, you can start if you are good following your patient and he's on multiple drugs. You can assess first which drug that had the least effect of control on the seizures. This you can detect from the previous history of the patient, and you can, from his agenda, from his previous physician, or from your previous following of the patient, just try to choose which of the anti-seizure medication that had the least good impact on the seizure control. And this one is the one that you start gradually of tapering and start withdrawing with.
Okay. Thank you. Another question, how can you define adequate seizure control?
Well, this would be the same as the question about
the same question.
Define patient who is free of. I'm sorry that some answers are not clear cut. Some answers are individualized for every patient.
Okay, of course, yes. Someone asks about EEG abnormalities without actual seizure. I don't know. Did he mean that the patient had a never seizure?
I think that means that there is no clinical manifestation of epileptic activity, and the patient by chance was detected to
By
have
chance, you detected EEG abnormalities?
yes, okay.
Yes.
Well, as we defined, epileptic seizure is the clinical manifestation of abnormal inherent synchronous discharges of the brain. So you cannot treat a patient that did not develop epileptic seizures, because a seizure is the clinical manifestation of epilepsy. If you want to start to give anti-seizure medication, what will you monitor if the patient does not have symptoms? So we always say that don't treat the EEG, you are treating the patient. Single EEG abnormality does not verify in most conditions starting anti-seizure medication.
Yes. This question was asked before.
Yes.
About discontinuation after epilepsy surgery. Another question. I want some clarification from Omar Abdulrahim. He said as he had early life stroke. Please retype your question. Now we have a question. What about the withdrawal of valproate? Is there any concern about valproate?
As we said in the presentation, you can withdraw valproate within a few weeks, even more rapid than carbamazepine and lamotrigine. So there is no any precautions. Just follow, as we say, you can start by tapping 10% of the dose or 25% of the dose every 1 or 2 weeks.
Yes, we said. Now we have a question. Is video EEG is mandatory to be performed before withdrawal or just level 1 routine EEG?
None of the EEG are mandatory to perform before withdrawal. This will really be on your own personal experience, whether you like to do an EEG or not. It will be one of the factors that may increase risk of withdrawal or decision, but as we said before, it is not the main issue that you can decide whether or not to withdraw. So you like to do video EEG, you like to do a routine EEG, this is as you prefer.
Thank you. Another question. One of the patients, while on withdrawal, she was on levetiracetam, 500 milligrams. She dreamed that she had a seizure, but there was no urine incontinence or trauma or anything abnormal when she woke up. Should we continue the withdrawal? I think he means that unwitnessed seizures during withdrawal.
It is a suspicious and it seems that he is not confirmed. Is it a real seizure or
Yes.
not? If he is suspecting it may be a seizure, right?
Yes.
Well, you can
Suspicious, not confirmed.
yes. Well, you can hold withdrawal for some time until be confirmed. Well, it seems that you have already started reducing the doses, so you can hold the reduction of doses and continue observing the patient. If she will develop further seizure, now reverse back to the doses before withdrawal.
Yes. Another question. Thank you for presenting this very informative lecture, but I used to ask myself when I face a patient with a stroke or post-encephalitis, structural disorder, or focal cortical dysplasia, do we have to withdraw anti-seizure medication at the end?
Well, usually patients with remote symptomatic seizure are at high risk of recurrence. So you have
Yes.
to weigh the more safe approach is to continue on the anti-seizure medication and not start withdrawal. If the patient has a decision to withdraw, if quality of life, if other factors are getting into the decision, you have to weigh it. But if you want a direct opinion for this case, it's better not to withdraw anti-seizure medication in remote epilepsy, remote symptom.
Thank you. We have a question. I have patients with tuberous sclerosis with good response on vigabatrin. Can I stand in treatment with vigabatrin for more than 6 months?
Well, if you are following his vision, if you are assessing him on frequent basis, I think it depends. You have to weigh between risk factor of the adverse event of the drug and the possibility of acquiring epileptic seizure. It will also depend on the size of the lesions, if the brain, presence of family history. Tuberous sclerosis is a very rich and part of symptomatic epilepsy. So you have to weigh other factors before taking the decision of early withdrawal of vigabatrin.
Yes. This question, the same was repeated about surgical epilepsy. Now, let's shift to another question. I forgot to precise that the patient has many side effects of phenobarbital. I don't know what he means.
I think he's the same person who asked about phenobarbital withdrawal in an elderly and before initiation of levetiracetam. Maybe he's please, if you can verify more.
Yes, please, we need more clarification for this question. Let us take another question. Do you advise to taper and quit therapy in elderly epileptic patients? Elderly.
As we said before, extremes of age are one of the factors that indicate high risk of recurrence. So if an elderly patient, if the seizure onset is in the late adulthood or in the elderly, this is high risk of recurrence. So if the patient is tolerating the antiseizure medication, it's better to keep giving the antiseizure medication rather than to get risk of withdrawing and getting further seizures.
Okay, another question. A patient with first unprovoked seizure, abnormal EEG. Should I start antiseizure medication?
Well, it also depends on this means that he has a high risk factor for developing. I think at this time you can discuss this issue with the patient. You should, if it will be more safe to start anti-seizure medication, being having abnormal EEG, especially if you have, you can diagnose a syndrome or this focal epileptiform discharges or generalized epilepsy. And if you find in the EEG epileptiform discharges, this is a high incident for recurrence. If you just found slowing or a non-specific finding, well, you can follow the patient. If it is you found epileptic activity of the brain, epileptiform discharges, that will be one of the risk factors of recurrence. So you can discuss this issue with the patient, and you can reach together with the appropriate decision together.
Yes. Someone asks if patients have focal discharge in EEG, but no seizure event, should we start anti-seizure medications? Again, he asks about that the first seizure has never occurred.
Yes,
only just abnormality, but focal. He means focal.
Yes. Okay. Well, again, you have to. This is it is a high risk for that he may develop, but you cannot only treat EEG. A clinical seizure must be evident. You have to investigate more if there are any clinical evidence of epileptic activity. follow the patient, take proper history again, ask about nocturnal events, see if the EEG supports any epilepsy syndrome, and then take your decision.
Another question. Some elements are repeated. He asking about definition of epilepsy, unprovoked seizures. Professor Riham Shamlul answered before. He asked about how do we explain for reading epilepsy, mesogenic epilepsy? I don't know. And how long the duration of free seizure cutoff before we decide to withdraw anti-seizure medication?
He maybe wants to know the difference between unprovoked seizure and reading epilepsy. Is the reading epilepsy an unprovoked? Since the epilepsy are provoked by reading, they are reflex epilepsies, and reflex epilepsies are dealt with the same as unprovoked seizure, because we say that the provoked seizure are those that provoke a normal brain. Yeah, when the brain is subjected, when normal brain is subjected to hypoglycemia, to hypocalcemia, magnesemia, it will become epileptic and it will discharge. But this is not an epileptic brain. An epileptic brain has an inherent abnormal activity to discharge epileptic discharges. So reading is not a common insult to the brain that will discharge an epileptic seizure. So this is an abnormal response to the brain. This brain is abnormal, responding to a normal stimulus. So reflex epilepsies are considered epilepsy. Okay, I hope this clarified the first question. How long during the free seizure? The second part stating about how long. As we said, it is it will
according to the system.
According to the situation.
Okay. Yes, it mentioned before. It was mentioned before. Yes. Another question: how should we follow the patient after withdrawal, by EEG or clinically or both?
No, you follow the patient clinically. Following the EEG does not have a big role in deciding to initiate or withdraw anti-seizure medication. It just adds on to your risk for the patient. So the main issue in following the patient following withdrawal is if any clinical symptoms occur. If the patient developed abnormal EEG, that will maybe increase the risk marginally, but not as if he developed clinical seizure.
Okay, another question. He asking about the risk of recurrence following withdrawal after 2 years.
Yes, we stated that 65 of the patients who undergone will continue seizure-free. 35 may recur even if we did not withdraw. We must save these figures when you are counseling the patient before starting the withdrawal.
Someone asking, what do you require for the withdrawal of phenobarbital after 6 months of use in order to replace it with another anti-seizure medication?
Yeah, I don't understand. What do you require for withdrawal? I'm sorry, but I do not get the meaning of the question.
Okay.
I do not get the question, Dr.
The one who asked it, may I please verify what you want? The someone who asked before about withdrawal anti-seizure medication in hemiplegic patients. Now he asked about that the anti-seizure medication can withdraw in hemiplegic or not, and if there is a specific time, like 5 years.
Is the hemiplegia the cause of seizure or not? This is the question. Is the
Yes, if, he meant that I think he asked it before in the CP, in one who had a hemiplegic and he was CP. So he had a focal neurological deficit, abnormal MRI. He asked if there is a specific time, like 5 years.
Well, let's be clear, if the hemiplegia is occurred first, then the patient developed seizures, yeah, meaning that the epilepsy is due to a remote symptomatic etiology, it's better not to withdraw the anti-seizure medication. Maybe you can prolong, don't hasten the withdrawing of anti-seizure medication in remote symptomatic causes. Prolong withdrawal as much as you can. We cannot specify a time, 5 years, 10 years. Wait until 10 years, then try. Yeah, but it will be individualized on individualized basis and on between you and the patient. But if put always in mind, in remote symptomatic etiologies, it's better not to withdraw the anti-seizure medication. It will be having a high risk. This patient will have, if he chooses to withdraw, they will be at high risk of recurrence.
Okay. Someone asked, can we stop continue anticonvulsants before an EEG procedure? Before doing an EEG, the patient had to withdraw or stop his anti-seizure medications or to continue?
Well, if the patient is seizure-free for a considerable period of time, if you think that the patient has passed like 2 years, so according to the individual characteristic of your patient, and there are a considerable time you seem sufficient to withdraw, it's not the EEG will not like prevent you from withdrawing. The results of the EEG will not prevent you from withdrawing. So if you can perform, if it's not feasible, if it's feasible to perform, you can perform. If it's not feasible to perform an EEG, more or less it's now more or less feasible. But if you can, it's not feasible to do an EEG and you see the patient has been seizure free for a considerable period of time, you can go on and start withdrawing and closely monitor your patient.
Okay. Is EEG mandatory before start tapping? Again, it is a repeated question.
Question, yes.
Another question, someone asking about any concerns about autistic spectrum disorder and anti-epileptic drug withdrawal.
ADHD is a common comorbidity in epilepsy syndrome. It depends on is your patient suffering from one of the epilepsy syndromes that is associated with with autism or not. Did you diagnose a syndrome or genetic disorder? I think it will be individualized according to the cause of seizure in your patient. Have you diagnosed a certain syndrome? Have you diagnosed a genetic disorder? According to, you can detect whether it's appropriate to taper the anti-seizure medication or not. I think this will be also individualized to your patient. What is the epilepsy he is, what type of epilepsy he is suffering from, and then we can take the decision, shall we taper or not the anti-seizure medication.
Okay. Is there any difference between new or old anti-seizure medication considering withdrawal?
We will, as we mentioned in the general rules, there is no specific rule for each anti-seizure medication except phenobarbital and the benzos that we have to prolong the duration of withdrawal. Most other anti-epileptic seizure, but generally, as I said, you can withdraw them within a few weeks to months.
Okay. Someone asking about a case of anti-epileptic drug withdrawal in a patient of postpartum breast. but with a positive family history of idiopathic generalized epilepsy.
So the patient became seizure-free in how much years? We need to know, the patient now developed epilepsy following breast, or he was non-epileptic and then he developed breast. This should be clarified. Does he have a structural injury to the brain upon which he developed, so we can consider him as remote symptomatic, or it is an idiopathic generalized epilepsy, one of the syndromes that is more or less has good prognosis, and we can tackle the anti-seizure medication. So which of which, remote symptomatic or an epilepsy syndrome? I think
I think
the
he
discussion
means
was
the,
needed.
I think he means a remote symptomatic.
Okay, the remote symptomatic, as we said, it's always we will go more to not withdrawing anti-seizure medication, especially
Yes.
if he's remote symptomatic and also had a family history. So this
Yes.
patient has high recurrent risk.
Yes. Do the 10 years seizure-free the condition of definitive healing, that we can
So
tell that the epilepsy is cured? Yeah.
epilepsy is never cured. We can say that even the definition, we say epilepsy is resolved. We have not
Yes.
the strength or the confidence to say epilepsy is cured. Because you are not curing. What medicine should we give to cure the epilepsy? Hoping in the coming years and the evolution of genetic management, we can cure the genetic causes of epilepsy. We hope so. But until now, you are giving anti-seizure medication and hoping that the long term of this epilepsy is good. And this is detected from the type of seizure or the cause of epilepsy, which we really don't know in every patient. So 10 years, 5 years, 15 years, it's all about studies and statistics. But the thing that really counts is the cause of this epilepsy. This the only thing that will really tell us when will it heal, if when it will be cured. But our knowledge till now says that epilepsy will be resolved if the patient is seizure free 5 years on the anti-seizure medication, and for more than 5 years without anti-seizure medication. If all is spending 10 years seizure free, 5 of which without anti-seizure medication, he is defined as epilepsy is resolved, not cured.
Yes. Yes. What happens if you withdraw lamotrigine or carbamazepine fast?
Well, it always the risk of rebound seizures that we are all fearing from. So gradual tapering is the most common path that we follow.
Yes. Another question. The first part was repeated again and answered before. The second one about non-convulsive status epilepticus.
Of course, we treat non-convulsive status. It is a non-convulsive state. It is a clinical manifestation. The patient, yes, is not having motor seizures, but he has electrographic seizures and he has disturbed conscious level. So, of course, you are treating non-convulsive seizures.
Yes. About the patient when she had withdrawn the levetiracetam, and she dreamed about that she had a seizure with no urine incontinence, with no any signs of focal trauma, and it was unwitnessed event, only just a dream. She asked about
you have a suspicion. You and the patient are suspecting, so you have to wait and see. Yeah, you just hold. We said, try. This is my opinion. You can just hold withdrawing at this at the dose you stopped at, and
Yes.
wait if she develops further seizures or not.
Yes. So we hold the withdrawal
Yeah.
shortly. Yes. When introducing a new anti-seizure medication, when is the right time for the first evaluation of efficacy? I mean, when should we increase the dose? For example, if the patient is still have seizures after 1 to 2 or 2 weeks, for initiating the levetiracetam at a dose of 500 milligram per day.
Well, it depends on each drug and the other or the pharmacokinetics of the drug. Did it reach the steady state? After each drug, you can detect if it reached a steady state and the patient is not controlled, then you increase the dose and go on until you reach the highest tolerated dose. And if no good response, you add on the other drug. It depends on the steady state. When will you reach the steady state of each drug?
Someone telling me that when you want to taper anti-seizure medication, it is preferred to start with tapering of benzodiazepine and then to taper other anti-seizure medication. Is that true?
If you want to withdraw the anti-seizure medication, start with the least effective drug that controls the seizures. This is the rational polytherapy we usually follow. So I think this is the best approach. If he is the drug that had the least effect in controlling the seizure, this the drug is you should start for by reducing it.
I think he means that because benzo had a common withdrawal seizures. Therefore, he prefers to start with it to avoid withdrawal seizures. Yani, if present, he will hold the withdrawal. If he passed, he will continue to withdraw the other anti-seizure medication.
Well, maybe that's another approach. It is another.
Yes. The someone he asked before about the question concerning phenobarbital. She said again, withdrawal of phenobarbital. Any concerns about this issue?
The withdrawal of phenobarbital, phenobarbital, or benzodiazepine all should be very gradually done.
Yes.
Over months.
The last question, after first epileptic attack, what's the best time to do EEG? Within 24 hours or later?
No, as early, you should do EEG as early as you can. Once it's feasible, do the EEG. The more close the EEG testing to the seizure, the more information it can give you to the epilepsy. Do not wait.
Yes, within 24 hours. Thank you, Professor Reham Shamloul, for this valuable answers. Is there anyone had further questions?
Thank you.
Thank you. Thank you. Now, I would like to express my deepest thanks to our guest speaker, Professor Reham Shamloul, for this valuable knowledge, lecture, and answers. Thanks to the organizers for inviting me to such opportunity. At the end, I would like to announce the following. The Global Health and Epilepsy Project database provides a registry of existing epilepsy projects through Africa, the Eastern Mediterranean, as well as in other regions. It identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. The database is quick and easy to complete. By submitting information in your project, you inform understanding of efforts that are occurring through the world to narrow the epilepsy treatment gap. The database will provide you an opportunity to learn from others and to explore collaboration opportunities that might strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas such as government, academia, nonprofit, or philanthropy to learn about existing efforts while offering a means to engage.